So you'll be giving some kind of a countdown?
Yes, sir. I will introduce you. Sir, we are live now.
Yeah.
With all your permission, I'm starting this session.
Sure. Go ahead.
Good evening, everyone present here. I am Faraz from IGCP Group. I welcome all the participant doctors on today's session. Let's welcome today's speaker with great honor, none other than Dr. Nidin Abhayankar, sir. Sir has done MBBS, MD in Internal Medicine, European Diploma in Adult Respiratory Medicine, Consultant Pulmonologist and Head of Department Pulmonary Medicine, Pune Medical and Hospital and Research Medical Center, Pune Course Coordinator Respiratory Therapy, Pune Hospital and Research Center, Pune Founder and Director School of Interventional Pulmonology. Today, sir is going to discuss on a topic, management of COPD. Let me tell you overview of the topic. And that is the COPD is a healthcare condition. To know more about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Yes. Thank you, Faraz, for your kind word and introduction. I'll just make sure that I'm sharing it correctly. So I hope my slides are visible.
Yes, sir, it's visible. You can proceed.
Thank you. To the audience, my warm wishes from Pune. And I work in Pune Hospital and Research Center, as it was introduced, and I'm a head of the Department of the Pulmonary Medicine. Today, we are going to discuss this important topic, COPD. And COPD is a common disorder. Almost nearly 12% of the people above 30 years in the world have it. In India, the incidence is believed to be anywhere between 6 to 10%, something of that sort. We have a little less. In fact, prior to the onset of COVID-19, COPD was the third large cause of death worldwide. But if you looked at India, it was already the second cause. Of course, COVID changed it for a few years, but I think now we are back to that number 2 killer position for COPD. So I think that's the magnitude of the problem, how much deaths occur because of this particular disease. Now, COPD it's not just about giving some kind of, the managing it is not just about practicing oral salbutamol, theophylline, cough syrups, antibiotics. So we have to set the management goals. And the important goals, because if you all are simply aware that COPD is essentially a disease caused by a noxious particle inhalation over a long period of time. The commonest being cigarette smoking or a BD smoking. But in Indian settings, chula also is an important cause for such things. So the aims that you have, management goals you have, is prevent disease progression, relieve the patient of the symptoms, improve his exercise tolerance, improve the overall health status, identify and treat the comorbid conditions, and there are many which complicate this disease, prevent and treat exacerbation. Preventing is very, very important here, and prevent and treat complications. So we'll try and see all these one by one. So preventing disease progression, and of course, the commonest thing that you can do is all the smoke that we can avoid in this world is avoidable. Whether it is a weed smoke or a cigarette smoke or a ganja smoke or even the mosquito coils, and so many examples that I've shown you in the pictures. There, the vehicle exhaust, the ambient air pollution, the pujaris, the acharis, everybody's exposed to smoke in a bad way. People who are cooking on a chula, so all that has to be minimized or nullified. And I think that is one of the important things. Is these are all the risk factors for COPD, and it is worth looking like that. For example, using improving having a chimney in a kitchen, that will help, or having a Philips stove will help, or low smoke chula, or of course going to the LPG gas is the much better option, or of course going to a other high-tech options also. So I think these are some of these answers. For example, rather than burning things, using barriers for mosquitoes and not burning the coils will be a great idea. So that's one part of it. The second component of this is relieving the symptoms. And we have to look at what kind of medications, because the main two symptoms patients will be complaining about is either one is breathlessness and cough. These are the two things which most of the patients are complaining. So this can be assessed by a simple score called as CAT score or a MMRC score. And here, this is the example of a CAT score where we are saying 0 is where I'm happy and 5 is where I'm sad. I never cough, I get a 0. I cough all the time, I get 5. I have no phlegm in my chest at all, is 0. And then depending on the score, my chest is completely full of phlegm. My chest feels very tight. When I walk up the hill or one flight of the stairs, I am very breathless. I am very limited doing activities at home. I am not at all confident leaving my home because of my lung condition. I don't sleep soundly because of my lung condition. I have no energy at all. These are the way the answers are. And then the total score will be charted out. This is one way of doing it. The other one, which we are more familiar with, is modified MMRC scale or MRC scale, or grade 0 is I only get breathless when I really do strenuous exercise, like for everybody else. And grade 4 is I'm too breathless to leave the house, or I'm breathless when I'm even dressing or undressing. And then there are grades in between. So that's the way you look at it. And then, of course, you also look at the lung function. The spirometry is the gold standard methodology of diagnosing for the first time when we are doing it. And I'll elaborate that on eventually in this. So if I have somebody who's having MMRC 0 to 1, that means not so many symptoms, or a CAT score less than 10, not so many symptoms, versus a person who's symptomatic, and whether he's exacerbating repeatedly or not. Somebody who is having just 0 to 1, mild or moderate observation, not needing hospitalization, or 2 moderate exacerbation, or 1 at least leading to the hospitalization. So that is how we decide the management of this. Let us just touch the principles. We'll come to the drugs once again. So a bronchodilator is there when the symptoms are mild and there are no exacerbations. When the person becomes more breathless, then you have to either start with a long-acting anti-muscarinic agent called LAMA, or LABA, long-acting beta-2 agonist. And then if I have, the group C is now gone, so I'll show you that in subsequent slides. The C and D are practically merged, and the approach is more or less the same. And it could start with a LAMA-LABA, maybe an additional of inhaled corticosteroid, and then there are various other ways of doing it. So I'll come back to this eventually. Let's first differentiate between asthma and COPD management. In asthma, inhaled corticosteroids take the center stage because it's a disease of airway inflammation. So you treat inflammation is the primary goal. ICS plus long-acting beta-2 agonist, low to medium dose eventually gets added, and sometimes we use a high dose. And once in a while, we might be using an anticholinergic. In COPD, the focus is on bronchodilation mainly, and the drugs which will prevent exacerbation, and therefore LAMA comes ahead of everybody else. So long-acting anti-muscarinic agent, either like tiotropium or now increasingly glycopyrronium. So I think that is this. And then at some stage you say LAMA plus LABA. So formoterol or formoterol, something of that sort gets added, or now even indacaterol, or there are drugs which are ultra long-acting beta-2 agonists also. And somewhere down the line, when there is either a severe disease, somebody is exacerbating, or has eosinophil count more than a certain, then the inhaled corticosteroid get added. So look at the difference between asthma. ICS comes first. Here, ICS comes as a last addition. Of course, it is not unimportant, but at the same time, the sequence needs to be remembered. That in an asthma, you do not start with only bronchodilators. You have to start with ICS. That is the way. And in COPD, it is the other way around. I'll just touch upon these drugs. There is something called as PDE4 inhibitor, and I'll come back to this again towards the end of this. Then there's something called as long-term azithromycin, which reduces exacerbations over 1 year. And once in a while, some phenotypes will require mucoregulators and antioxidants. So there are the other anti-inflammatory therapies. We'll discuss this in detail towards the end of our talk. So Let's now proceed ahead and see, can we improve the exercise tolerance or improve the health status of these patients? So some of these can be tried, things like yoga, pranayama, formal pulmonary rehabilitation may or may not be possible, but simple things like Tai Chi or yoga, which are practiced everywhere, a regular walking, firstly breathing, and training of the diaphragmatic breathing also is helpful. So these are the simple things which people can do, and they can be helped in their pulmonary rehabilitation process. Now, identifying treating comorbidities, I'll go briefly and touch these comorbidities ranging from hypertension, ischemic heart disease or arrhythmias. Very common association is osteoporosis, and in pink puffers, people have profound weight loss. Patients with IHD and arrhythmias are at risk of more likely to have a COPD. So if I find somebody with hypertension or ischemic heart disease, also look for COPD and vice versa. And of course, they will have a higher chance of congestive heart failure. They are more likely to be anemic, and they are more likely to be diabetic. So keep looking for these comorbidities when you deal with a patient with a COPD. So I think it's not that all of them will be there, but some of them will be there, and you have to address them. And preventing and treating exacerbations. Now, preventing and treating exacerbations, everybody, even a healthy person, has a decline in the lung function with age. COPD, who has not had any exacerbations, also declines, but tends to decline a little more slowly. But a COPD who's getting recurrent exacerbations, he more rapidly deteriorates. And therefore, preventing exacerbations is one of the most important targets in COPD management. And we'll come to that again. One of the ways of protecting the failing lungs or weakening lungs is COPD vaccination and influenza vaccination. I think we are today now using, for example, Influvac Tetra or quadrivalent flu vaccine once in a year. It is not necessarily September, October, because in India, the season is all over the flu season is right now even on, and it is worth giving it worthwhile. So I think that is something which is very, very important to do. Influenza vaccine, it reduces the risk of post-influenza acute exacerbation of COPD related heart attacks by 50 to 80%. So this is just looking at the heart attacks. So many other exacerbations, related complications, admission, cost, all this will be given. In Japan, for example, there is a law to give influenza vaccine to all COPD who are more than 60 years, 65 years. In fact, we do it for even our asthmatics. The flu vaccine is not a problem. Pneumococcal vaccine is also an important vaccine. And right now, what we have is PPSV23 and PCV13. So there is a polysaccharide-based vaccine which needs to be administered, as well as PCV13. Today, if I have to do it for a COPD who is more than 65 or even less than 65 with significant comorbidities, then I would give conjugate vaccine first, and a month later down the line, I will give PPSV23. Once PPSV20 becomes available, PCV20 will become available, then a single vaccine will be enough. You don't have to do polysaccharide and conjugate, because conjugate currently is having less pneumococcal variants or strains covered, 13 only. So once it becomes 20, it is as good as PPSV23, and therefore then the overall immunity induced by PPSV23 is better, and therefore we focus on that. And of course, then there are some people who will require the DPT booster dose in some of these situations. If you look at the neck, this is not for every COPD, but that phenotype which is having a lot of mucus secretion and difficulty in coughing, they are benefited, and you can see that there is a lot of reduction in overall exacerbations when people are put on this particular drug. This is a Pantheon trial for a fairly large number of trials, which shows more effective in patients with moderate disease than in patients with severe disease. So NSAID system introduced early in this will be worth it. If despite all this, and my patient is on LAMA-LABA or LAMA-LABA ICS, still he exacerbates, then what will I do? So I will be treating this patient with inhaled bronchodilators, SABA, like Levolin or whatever that you are using, and ipratropium bromide by nebulization. So the typical commercial combination available would be Duolin, and I'll be nebulizing that. Low dose oxygen, so 2 to 3 liters of oxygen, just to correct it to 94, 95. Don't push the oxygen too high. When needed, non-invasive ventilation early. Somebody who's tachypneic, breathing at a rate of 45, 40, 45, and likely to go into respiratory failure, it is good idea to put them on this, particularly with CO2 retention. Good idea to put them on this. Some amount of prednisolone, say typically 10 mg per day for 5 to 7 days. Antibiotics if there is a coexistent bacterial infection, and very often we use it here. In asthma, we don't use antibiotics. In asthma exacerbation, in COPD, we use it. And then put the patient one before discharge on LAMA and ICS, preferably, because he has already had an exacerbation. So he's one of the person who qualifies for it, and consider other options, and we'll come to that eventually. So did I achieve, once at the end of this, did I achieve all my goals? And preventing and treating complications remains the last one. What are the complications? The commonest you will get in, say, a pink puffer or emphysematous individual is some pneumothorax, which you may have to drain. Treating pneumonias is important. Anemia and polycythemia correction. Anemia on one extreme, polycythemia rarely you will come across, but you may have to deal with it. Sometimes you have to treat pulmonary hypertension. If it is a mild pulmonary hypertension related to hypoxemia, don't treat it with drugs, treat it with oxygen. That is the answer. Cor pulmonale and congestive heart failure will need diuretics and so on and so forth. So that's how you will go ahead with this. Despite this whole story, India is so full of, and in fact, if you really see, first of all, the important statement here is 80% of the COPD is the non-smoking COPD because of the ambient particulate matter or household air pollution or tobacco smoking in a much smaller percentage, 16 to 20% only, and occupational others like pujaris and acharis, as I said. So those are the examples, and the kind of days lost because of the are like, from state to state, they are worse. And for example, states like West Bengal, Bihar, or Uttar Pradesh, or we used to once upon call them Bimar, now they are much better. But then they require much more resources, and they have more exacerbations as compared to Goa, Nagaland, and so on and so forth. So I think we're not going to go into the geographical variations in India details. Occupations at risk of chronic obstructive disease, this is lifetime. A sculptor or a painter, even a gardener, a park keeper, farmers, warehouse stockholders, fishing industry, and even sports. So some of these are exposed to some kind of noxious particles once in a while, and they need to be sort of, so these are sort of emerging new occupations world over, which people are identifying that, yes, it's not only just a smoker, but there are some other, or pujaris or acharis in our country. But I think there are some other people who are exposed to such noxious particles and stimuli, so on and so forth. So I think I'll go ahead. Now, if you look at it, as we said, LAMA is the first option. So it used to be tiotropium. Today, it is more or less glycopyrronium. Tiotropium used with say 9 micrograms inhaler, 2 puffs once in a day, or 18 microgram rotacaps once in a day. Glycopyrronium typically used in 50 micrograms per day, 25 twice daily, or otherwise. It can be used again in an inhaled form as well as a rotacapsule. It is available as a 50 microgram rotacapsule. Then there'll be tiotropium and formoterol, or glycopyrronium and formoterol. And then there are, as I told you, towards the end, in some patients, we will require inhaled corticosteroids. Budesonide is the most commonly used agent worldwide, but you can use cyclosinide, you have been using, and fluticasone fumarate has come in a big way in the last few years or so. So I think that's another one. Once in a while, there'll be a long-acting theophylline once in a day in a very small dose. Typically, I use only just 100 or 200 milligrams of theophylline in order to avoid complications. And this sort of sensitizes the steroids to work better. And when do you add them? When do you add inhaled corticosteroid to this cocktail? One, when there is a clear-cut asthma COPD overlap. So there is a clear-cut asthma component to this COPD that you are treating. Then second is the people who are having recurrent exacerbations. and people who have a blood eosinophil count in more than 300 cells per ml. So I think that's the way. So now I'm going to go, I've sort of more or less touched upon the basic principles. I'll try and go into a little depth of each and every of these components and as best as we can. In a less severe COPD, the symptoms and exacerbations can be controlled with simple ideas like smoking cessation. Simply to say, difficult to actually achieve, but worth doing it. And you have molecules like bupropion and varenicline and to help the patients when needed. Vaccination against influenza and pneumococcal, we have seen that in detail. Attempting pulmonary rehabilitations early on when the dyspnea starts, and that might help a lot in many of these patients. And one or more of these inhaled medications, initially the bronchodilators and eventually a glucocorticoid will get added. So if you look at it, these are the latest kind of recommendations. Said for dyspnea, what will work, and for exacerbations, what will work. So dyspnea, LABA, LAMA, or LABA plus LAMA, and then consider switching the inhaler device to molecules, implement or escalate non-pharmacological treatment, investigate and treat other causes of dyspnea. So dyspnea could be addressed by these. Exacerbations typically will require one LAMA more effective. If the blood eosinophil count is more than 300, then adding inhaled corticosteroid makes sense. If it is less than 300 and I am only on LAMA, add the LABA to it. So LAMA-LABA becomes the combination. And if the blood count is, say, about little more than 100, then again you will add LAMA-LABA ICS. Now this is the most important part, that if I'm exacerbating despite this, then I have two options. One pathway takes me to roflumilast if there is an FEV1 which is less than 50 and the chronic bronchitic phenotype exists. So that means there is a lot of mucus production on daily basis. And former smokers preferentially are put on azithromycin in low dose. Low dose, this is not used as an antibiotic, but immunomodulator is 250 milligrams once in a day or 500 milligrams 3 times a day. So that brings us to the relatively refractory COPD. Now, this is something which is, despite the reasonable therapy, person continues to have a refractory dyspnea, continues to cough, and has recurring exacerbations. And this is despite therapy with a LAMA or a LAMA-LABA and sometimes even ICS. For the addition of pulmonary symptoms, these patients also may have additional problems of fatigue, weight loss, sleep disturbances, and anorexia. So they also become your treatment target. Once again, you start with looking at your basic, what was the lung function before at that point in time. Now look at where are on MMRC scale. Most of these will be on stage 4. On a COPD CAT test, they'll be generally closer to 20 or maximum or even more than that. So again, a revision of that MMRC scale. And this is very important that after doing all this, so you have a spirometrically confirmed diagnosis where a post-bronchodilator FEV1 on FVC ratio is less than 0.7. Look at the airflow obstruction. And if it is, say, FEV1 is more than 80, it is gold stage 1. 50 to 79, it is gold stage 2. Like that, you go on. And if it is very severe, then it is gold stage 4. Then take the more exacerbations history. Somebody who is getting recurrent exacerbations, getting into the casualty, getting into the hospitalization, then he is called as group E. So as what I showed you is group C and D is now merged as group E, irrespective of whether he is symptomatic or not. If he is exacerbating, he is called group E. Whereas those who are early ones, and I think the early ones I have talked to you in detail, that this will be only a bronchodilator, and this will typically be a bronchodilator combination of LAMA and LABA most commonly. But in group E, invariably you add ICS and then consider azithromycin versus PDE4 inhibitor. So that's the way. This is again an example of a CAT score. And also these patients who are having refractory COPD, they will also, apart from having a very high CAT score, which will be closer to, so now 5 multiply into 7 or 8, so it will be 30 plus or something like that. they will report increased periods of increased dyspnea. There is extra sputum volume, and the sputum starts becoming purulent. So also have to look for antibiotics. You have to look for the germ. You have to do a culture, and treat it, and once in a while have to use nebulized antibiotics also in some select situations. COPD hospitalizations mark severe exacerbation. So somebody is in a hospital, invariably has to go on a ICS triple. That means a LAMA, LABA, and ICS. And somebody who is reporting fatigue and sleep disturbance, you have to look at it. There are some people who still are continuing to smoke, so that you have to restock to them other, look at the other exposure history, what noxious particles are they exposed, and if there is available lung function previous or otherwise. So relook at the lung function once again. Is this patient using accessory muscles of respiration and the shoulder girdle? Is he breathing with pursed lips? Is he cyanosed? Is he having asterixis because of a severe hypercapnia? And once in a doubt, if somebody who's looking dodgy on the sensorium, look at the ABG, arterial blood gas, and it will tell you that this person is retaining carbon dioxide. Is there a liver which is tender, suggestive of congestive failure or a peripheral edema due to the right heart failure? Please look for that. A falling body mass index is very common in severe COPD, typically because of the emphysematous individual who goes on getting more and more cachectic. But there are people who also have rising BMI, and it may suggest fluid retention due to right heart failure or a comorbid heart failure. In these present, then decreased mental status scores reflect hypercapnia or hypoxemia. Both hypoxemia and hypercapnia will make you little wobbly there upstairs on the CNS part. Other physical findings such as digital clubbing, biobasilar fine crackles, peripheral edema sometimes may suggest another disease like interstitial lung disease, which is superimposing on this. So you generally don't get those basal fine crackles in COPD alone. Now, when you are treating people, I think one of the most important things to worth remembering and following is keep the inhaler regimen simplified. So one rotahaler, the other inhaler, the other one with a spacer, 3 different devices and 3 things. Rather than that, try and choose once or twice daily single inhaler triple therapy, LABA, LAMA, or ICS. So I think that is if you are using a LABA, LAMA, put it together in a single inhaler. If I'm using LABA, LAMA, and ICS, put it together in a single inhaler and use once or twice daily preparations. And lot of such preparations are available for most of our patients. Just check. Yeah, we are nearly at the end of our lecture talk. So patients with refractory symptoms, despite optimized inhale therapy, we reevaluate the airflow, look at the lung volumes, and here doing a detailed body plethysmography is going to be important. What kind of air trapping this patient has, what kind of a gas exchange, DLCO, this patient has. Do an ambulatory pulse oximetry, do a 6-minute walk test, and how much is he desaturating, and how much he is able to walk, and how much is the impairment in it, and arterial blood gas at rest, because hypercapnia is a marker for an early death eventually. Generally, when you are looking at such patients who are morbidly ill, at least one CT evaluation, which will rule out a new interstitial lung disease, a new lung cancer. If there is pulmonary edema, that can be picked up in this. Sometimes you get indirect evidence of pulmonary hypertension in the terms of a dilated pulmonary artery and so on and so forth. Central airway obstruction once in a while could be picked up. And if there is a coexistent bronchiectasis or bronchiolitis, so CT imaging is helpful. Also look at a 2D echo from time to time, because the cardiac comorbidities are very many. The cor pulmonale does come with an advanced disease, and obtain in echocardiography definitely when the patient starts getting what is called as refractory symptoms. There is a significant overlap between this and obstructive sleep apnea, and therefore always it's important to take a sleep history. Sometimes difficult because COPD patients don't sleep very well as such, and they're getting that correct history, whether he's snoring or not, whether he's stopping snoring or not, and once in a while you may have to do a sleep evaluation with a polysomnography. and maintain a low threshold to obtain cardiac stress testing in patient whose dyspnea could be because of consistent with angina. So keep these two diseases, obstructive sleep apnea and angina, in your checklist when you are dealing with a refractory patient who is not responding to the conventional therapy. Once again, help patients by quitting smoking, maximize their physical fitness, receive appropriate vaccinations against various infections, select patients with COPD who may develop benefit by supplemental oxygen. And this is where another important intervention comes in, and we'll see exactly how, at what level we will put it on, but giving home oxygen, improving their nutrition, and once in a small subset of patients, introducing nocturnal non-invasive ventilatory support, partial support, say 8 hours in the night, 2 to 3 hours in the day, and say 10 to 12 hours totally may do great help and may add years to these patients' life. So one by one, let us see home oxygen. Long-term supplemental oxygen is recommended for persistent chronic hypoxemia. Somebody who's having a PaO2 less than 55 or a pulse oxygen saturation less than 88, and the target is corrected to 88 or 90, don't correct it to 99. Less stringent criteria, PaO2 even less than 59 or a saturation less than 89 is used if there is already a cor pulmonale or right heart failure or a erythrocytosis with a hematocrit more than 55. We are not very sure whether this generally reduces the dyspnea and exercise tolerance in patients with mild to moderate exertional dyspnea in the presence of absence of hypoxia at rest, but most patients will show improved exercise capability with supplemental oxygen, particularly when they are little more severe and they have more severe hypoxia. The nutrition, presence of a pulmonary cachexia has been traditionally determined by weight of less than 90% of the ideal body weight, or even in body mass indexes typically less than 20, like typical pink puffers. More than 30% of the patients with COPD have protein calorie malnutrition, and therefore augmenting their protein, preserving their respiratory muscle function by using that, correcting the diminished immune response, not putting too much load onto the carbohydrate. So minimizing or giving less carbohydrates, giving appropriate proteins and a reasonably little extra fats is what is the principles of nutritional therapy. Home NIV is not for everybody, but a small but a definite percentage of patient falls into this criteria where they are having daytime hypercapnia or nocturnal hypoxia, will responsive to and which is not responding to supplemental oxygen during sleep. So even despite on oxygen, if they have nighttime hypoxemia and daytime hypercapnia, you will consider them. And a reasonable threshold for daytime hypercapnia that facilitates, forget the insurance coverage, but if a PCO2 is more than 52, in our situation, chronically, I would look at maybe more than 60, and that would be an appropriate target for them. Many of these patients are stable hypercapnia also, so not everybody will necessitate it, but some of them really, really benefit. And more mild hypercapnia, home nocturnal flow, high flow therapy by nasal cannula may also decrease exacerbation frequency. This is right now not available in our situation, but low flow oxygen is available. So I think we have touched upon all these drug concepts, and we will try and go into the little better depth of the additional pharmacotherapeutic agents. What are those? Roflumilast, chronic low-dose azithromycin, persistent patients with breathlessness, monitor theophylline and a low-dose opiates very rarely towards the end of their life. Low-dose theophylline, mucolytics, and oral glucocorticoids are sometimes used, but the lack of efficacy and adverse effects greatly minimize their utility. I usually would not put my patients on oral glucocorticoids unless until I'm absolutely dead against the wall, and a very tiny dose, and that too tapered early. Whereas low-dose theophylline and mucolytics can be easily administered to these patients. We'll touch upon two of these groups in a little more depth. Azithromycin 250 milligram once daily or 500 milligram thrice per week, so alternate day, reduces exacerbations in patients who are prone to exacerbations. They may be having anti-inflammatory properties in addition to their so-called direct antimicrobial function. Lower dose of 200 milligram 3 times per week is sometimes used if I get side effects, but it has not been rigorously tested. So I would not recommend that. I'll stay with 250 milligram once in a day. And the optimal therapy, we are not very clear, but 12-month courses are or even longer. And some of my patients have used it for 2 years, even 3 years, and they do very well with this. What you have to watch for? Deafness and QT prolongation. And these two things have to be monitored. Somebody reducing so an audiometry at least once in a year and a regular ECG with QT. PDA4 inhibitors, roflumilast, is useful in some of these patients, not all, but some of these patients, and particularly as I told you, the chronic bronchitis phenotype. And it in PDA4 inhibition may demonstrate this effect by decreasing airway inflammation and promoting airway smooth muscle relaxation. The added benefit of roflumilast therapy on a background of other respiratory medications that reduce exacerbations appears modest. So if you are using LAMA, LABA, and inhaled corticosteroids, and then you add roflumilast, which is what we are going to do when you are really up against the wall, the benefits are not dramatic, but they are modest. Around 25% reduction in the exacerbations at the end of 1 year. But 25% is a great deal for people who are desperate and towards the end of their life. So I think this is something which is mainly for the future. This is early data on this. People with peripheral eosinophilia, dupilumab has been found to be useful in reducing exacerbations and improving airflow obstruction, but this is right now neither available in our country nor it is clinically used. So with that, I take your leave from the didactic top part of it, and depending on what my moderators tell me, we'll be taking the questions. Thank you very much. I'll stop sharing my screen.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one. I definitely think this session knowledge is going to help all the participants who have joined this session.
Thank you very much.
I can see, sir, we have questions for participant. If you allow, can I take this question with all your permission?
Yes, please. Absolutely.
Yeah. First question I can see from Dr. Agarwal. He is asking, how are arterial blood gas, that is ABG, finding used to determine acuteness and severity of the chronic obstructive pulmonary disease?
Yeah. See, you are not going to do an ABG every time or every time the patient comes to you. It will be done, particularly if you find that the patient is a little obtunded and you are likely to look at hypercapnic respiratory failure. So high carbon dioxide, that is one thing which you have to pick up. And if the patient is refractory hypoxemia, for example, your saturation is repeatedly 73, 74 in the OPD, then of course blood gas is necessary. Now, how will we know the severity? If this is not caused by, say, a congestive failure, it is not caused by any other cause, if there is no interstitial lung disease, then the whole process is caused by what? It is caused by chronic muscle fatigue, which is causing the hypercapnia and a very bad lung exchange. His DLC also must be very low. So therefore, there is hypoxemia. So again, you know that this is severe COPD and therefore you will treat it accordingly. So I think then thinking of home oxygen, and in patients who have chronic hypercapnic, typically people who have 2 admissions because of chronic hypercapnic respiratory failure, you will consider home ventilation also in addition to oxygen. So oxygen is not taken away. Oxygen is continued in low flow. Low dose home oxygen of 2 to 3 liters is a hallmark, the mainstay therapy for chronic hypoxemic COPD. But when there is a hypercapnia, you start considering using non-invasive ventilation. So I hope your ABG question gets answered by this.
Thank you so much, sir, for explaining it really well. I hope that Dr. Agarwal has received his answer. Moving forward, I can see few more questions from Dr. Ayushi Patnaik. She is asking, what are the elements of pulmonary rehabilitation program in chronic, that is COPD management?
I'll tell you one thing. COPD formal rehabilitation programs include, in principle, there are few things. Exercise, which is targeted starting at around 25% of their peak capacity and then pushing it to around up to 50%. Walking is the mainstay of that, and walking in with help of oxygen if that is required, then that is what it is. Some people are recommended cycle training or stationary cycle training. So some amount of aerobic activity is added. Then in order to improve the muscle strength, some amount of upper body as well as lower body exercises are added to this. And then depending on how many repetitions a person is tolerating, that is added. And then the breathing techniques and various breathing techniques. I think we don't have to necessarily go to, the conventional per sleep breathing. We could use the basic Indian techniques like pranayama and combine them with per sleep breathing. So I think these are the simple components of this, along with some amount of nutritional advice which is added, some amount of psychiatric counseling which is added. So pulmonary rehabilitation is not one single from exercise only. You rehabilitate them at as many levels as you can. Vaccination is also a part and parcel of that. But I think the focus of course has to be on rehabilitating them to do more and walk more. I think that is the basic principle of rehabilitation.
Thank you so much once again, sir, for answering this question. Moving forward, I can see last question from Dr. Istiaq. He is asking what is board index and how is used to estimate the prognosis of COPD.
Yeah, I think a board index is a little more complex. It is meant to be used in the hospital setting. So I wouldn't know my audience from that point of view. So, but breathlessness, oxygen saturation level, the spirometry and exercise tolerance and on all those put together, and then there'll be an index. So this has been a very useful index. It has been found to be correlating very well with the predicted survival, the kind of exacerbation prediction. So at multiple levels, it is useful. But if you really ask me from the point of view of practitioners, we're not on daily basis. I'm not using board index to treat my patients because the clinical algorithms with the CAT score or a MMRC scale and their basic saturation, and it is very easy to measure a pulse oximetry saturation and exercise 6-minute walk test. So I think simple things can tell you nearly the same thing that board will also tell you. Thank you.
Thank you so much, sir, for answering all the questions, sir. As I can see, there is no more question from the participant end. As there is no more questions, sir, shall we conclude this session with all your permission?
Absolutely. Absolutely.
Yeah, but there I can see, sir, there is one feedback from Dr. Ayushi. She has written, thank you so much for this wonderful session. It means a lot.
Thank you.
Thanks for information.
My pleasure and privilege.
Okay, thank you so much, sir. And till then, take care of yourself, sir. Hope to see you again with different topic in future, sir. It was a really wonderful to have you in our platform, sir. Bye, sir. Take care.
Bye-bye.
Welcome, sir.